Life moves fast, and so should the answers to your biggest questions. Welcome to Endo Battery's Quick Connect, your direct line to expert insights. Short, powerful, and right to the point. You send in the questions, I bring in the experts, and in just 5 minutes, you get the knowledge you need. No long episodes, no extra time needed. And just remember, expert opinions shared here are for general information and not for personalized medical advice. Always consult your provider for your case-specific guidance. Got a question? Send it in, and let's quickly get you the answers. I'm your host, Alana, and it's time to connect. Welcome back to Endo Battery Quick Connect, where we keep it real, recharged, and ready to dive deep into the realities of living with endometriosis. Today, I am thrilled to welcome a guest whose expertise sheds light on an often overlooked part of the endo journey, the bladder. That's right. Those frequent trips to the bathroom, the urgency, the burning, the pressure, it's not just in your head, and it's not just your uterus. Joining us today is Dr. Yaniv Larish, a board-certified urologist who brings both compassion and clarity to the table. He's here to help us untangle the complicated relationship between endometriosis and bladder symptoms. Let's get started. What are some of the things that you notice for those that when you're going into surgery and you know that you're going to have an involvement in that surgery? What are some things that maybe the patient describes that cues you guys into?
Yes. So I typically get involved whenever the patient complains of urgency, that when they got to go, they got to go. Frequency, meaning they're going more often than their peers. Nocturia, meaning they're waking up in the middle of the night. Feelings of incomplete emptying of the bladder. Whether that's perceived or simply fact is irrelevant. If they feel like they're not emptying the bladder, that's a problem. Urinary incontinence, fecal incontinence. And, it's funny, if you ask anybody with endometriosis if they have urinary incontinence or fecal incontinence, the answer is always no.
Mm-mm.
Nope, I don't have it. But if you ask them, do you wear a pad every day? Is the pad wet at the end of the day? No, but that's just discharge. No, it's not. There's something else going on there. Or fecal incontinence, do you have a hard time getting clean after you finish pooping? Do you have to wipe 1,000 times to get clean?
Mm-hmm.
And so we have sort of a set number of questions that we ask to sort of figure out who needs to be involved in a case if it's particularly challenging. And obviously that's part of the battery of testing, of questioning that we do. As you know, the problem with endometriosis is among the many problems with endometriosis. One of the biggest challenges with endometriosis is that there's no test short of the surgical intervention, right? There's no gold standard test. And so if you don't ask the right questions, it's very hard to get a good intuition or sense that the patient may have it. And the questions are, they're difficult to sort of get to the bottom of, especially if patient's been poo-pooed by a doctor 1,000 times or by 1,000 doctors 1,000 times. So it's challenging. But I will say that's typically how I get involved, is if we feel that there's a problem functionally, or of course, if we have imaging that demonstrates, obstruction or frank involvement of the urinary tract, whether it's in the ureters or in the bladder, then of course, my involvement is reconstructive in nature.
What do you see though after so you get in there, you do all the work? Are there issues that some of these patients have after that reconstruction?
Yeah. Look, every surgery, there's no such thing as a free lunch, right?
Right.
And so, to think that we can do surgery without having some trade-off is intellectually dishonest.
Right.
So you can have somebody who has horrific 10 out of 10 pain, 29 out of 30 days a month and fix that, but that might come at a cost of not emptying your bladder well, right? If the nerves are involved and you have to remove the nerves that govern bladder function in order to get relief of pain, you're going to sometimes see that.
Right.
And that's something that needs to be dealt with.
Right.
Same thing with defecatory dysfunction. It's a similar sort of problem. Obviously the way that we do surgery, we preserve nerves and we do a really, really nice job of sort of limiting the negative sequelae of surgery.
Right.
But we also oftentimes see cases that are second opinion, third opinion. They've already had 2 or 3 surgeries. Sometimes the damage is already done. And now the job is to sort of undo the effects of a hurricane after it's gone through.
That's a wrap for this Quick Connect. I hope today's insights helped you move forward with more clarity and confidence. Do you have more questions? Keep them coming. Send them in, and I'll bring you the expert answers. You can send them in by using the link in the top of the description of this podcast episode or by emailing contact@endobattery.com or visiting the endobattery.com contact page. Until next time, keep feeling empowered through knowledge.